Hello, welcome everybody. This is a Thriver series interview for Conversationally. Today I'm here with my co-host Deborah. My name is Bisa, and we're also here with our guest today, Dr. SibaHaykal. Did I say that right?
Yes.
Okay, perfect. Dr. SibaHaykal, and she is a very accomplished woman, so I'm going to read. I'm not going to pretend I remembered it. She's a surgeon and investigator, a plastic and reconstructive surgeon with subspecialties that include, but not limited to, breast, congenital and acquired skin conditions, hand, skin cancer, trauma, head and neck, and microsurgery, and as well lymphedema, which is why she's here today. She's also an oncological, reconstructionist, an assistant professor at U of T, an affiliate scientist at Toronto General Hospital's Research Institute, an associate member of the Institute of Medical Science, and she also leads the UHN, and that's the University Health Network for anybody who doesn't live in Toronto, the UHN's Breast Cancer Lymphedema Program. Welcome, Dr. Haykal.
Thank you for having me.
So I'm glad to have you here. And Deborah is going to start with our first question today.
One of the first things that I could think of to ask you was, what drew you to your specialty?
So I remember when I was much younger, and I was very interested in biology, and especially human biology and nutrition and sports, and I was very involved in a lot of sports. And I remember watching something on TV, and it was Médecins Sans Frontières, so Doctors Without Borders. And they were following a group of surgeons who were doing a lot of international work. Most of these surgeons were plastic surgeons. So these were surgeons that were operating on children that had some congenital malformations. And I remember them showing the amount of time they spent in the operating room on this very young patient. And what I remember feeling after that is how they changed this person's life and how important they were in making this child feel better and really improving his quality of life. So that was the first probably, I didn't realize they were plastic surgeons at that time. And then later on, when I went into medical school, I realized I kept an open mind, and I just wanted to make sure that I was a well-rounded physician, and I really enjoyed everything. And then I shadowed another female surgeon when I was in first year of my medical school, and she was doing a breast reconstruction. And I didn't realize that plastic surgeons were basically had to know the anatomy from head to toe and were able to operate anywhere on the body, but they were changing these patients' lives in a very different way. And I realized that, as a plastic surgeon, you have to be quite innovative, and you have such a huge effect on people's lives, and then it was in a very positive way. So that's really what drew me to this specialty. And, and then it's just there's so much breadth to this specialty. There's so much that you can do. So that's really what attracted me to plastic and reconstructive surgery.
Amazing.
Okay. So 2021 is fast approaching. We're almost at the tail end of the year. We want to ask you, what are you hoping to bring to the UHN's breast cancer program, lymphedema program, in the year to come?
Yes. So I was recruited back to the UHN about almost 3 years ago. And I had done some subspecialty training in microsurgery in the United States. And I actually took a job there, and I was working there. So when I came back, one of my main goals was to not only expand the clinical portion of the lymphedema program, but also the research portion of the lymphedema program. So over the past almost 3 years, we have been able to perform more surgeries in this field. The most common surgery being a lymphovenous bypass or lymphovenous anastomosis. And I have collaborated on a lot of different projects with some of the fundamental researchers, such as the radiation oncologists, looking at things like mRNA and protein profile and genetic profiling in patients who have lymphedema. So my goals for 2021 is to continue to expand the research portion of it. So more specifically, I'm looking at long-term outcomes and follow-up from the LVA surgeries, and not so much focusing only on the quantitative aspect, so the volume, but also focusing on improvement of quality of life. And how these patients, after their surgery, whether or not they have actually seen any benefit, even in terms of their symptoms and how they feel and the heaviness of their limb, for example. So I'm hoping to, so we have an RAB right now that we're waiting for approval, looking at outcomes following these surgeries. And we're hoping to continue to expand the fundamental research portion of it. On the clinical side, I hope to also bring different techniques. So currently, even though we're doing some of the bypasses, I'm hoping with some novel imaging techniques, I'm hoping to do further lymph node transplants and be able to offer some liposuction techniques, which are also very specific to lymphedema for some of these patients who might not be candidates for the physiological microsurgical techniques.
Oh.
Amazing.
Okay.
So needed.
Factions to the program with the liposuction.
Yeah.
So more people will be eligible.
Yes. So the liposuction techniques are very different than the regular liposuction techniques because they require very specific cannulas that, and the way they are done, they're supposed to preserve the lymphatic vessels that are there. So, and it's, it's one of the techniques that is talked about mainly in Europe, and it requires special training. So I'm hoping to further advance that program to be able to incorporate that in our clinical program here.
Okay.
Wow.
Okay.
That's so needed. So needed. So, of course, we're going to get into some terms because we want people to understand some of the terms that we need to know when we're looking at what your specialty is and what they need to be asking for. So can you describe what a lymphangiogram is and an infrared spectroscopy is and how they work as diagnostic tools for lymphedema?
Yes. So a lymphangiogram is where a radionuclide dye is injected in the web spaces. So if for upper limb lymphedema, it's typically injected in the web space of the finger. And for a lower extremity, it's injected between the toes. And it's typically done on both sides for comparison. So a lymphangiogram, which is what I initially do when I see a patient with lymphedema, allows us to track the lymphatic fluid and to assess the flow of these vessels. So basically, the patient gets an injection, and then they have to wait for quite some time before they get scanned. And what that imaging allows us to show is whether or not there are still any working lymphatics, where is the site of obstruction, is there actual lymphedema? Some patients, present to me with a diagnosis of lymphedema, and their lymphangiogram shows normal lymphatic function. That's not to say that they're not necessarily at a stage 0 or an earlier stage where they have some of the symptoms of lymphedema, but we know that their lymphatic vessels are still working. And so basically it allows me to figure out not only what stage they are at, are there any working lymphatics in the distal portion of the limb that are amenable to bypass. The other technique that I use is ICG, like it's a fluorescent dye. It's called an indocyanine green. And then you use what we call SPY imaging, which allows us to also map out the lymphatics. So this technique I use in the operating room, where I inject a fluorescent dye in the web spaces as well. And then I use the infrared. I wait a little bit of time, and it allows me to see very different patterns Some of these patterns represent what the vessels actually look like and what their function could be. So when we see a linear pattern, we know that there's normal flow of lymphatics. When we see a stardust or a scattered pattern, we know that the lymphatics are not working so well. And when we see a diffuse pattern, this represents more a type of obstruction. And again, this allows me to map out the lymphatics in order for me to try to bypass functional lymphatics into the venous system. So the second technique is used in the operating room. However, my goal is to try to have access to this in the clinic as well, because there's a lot of patients where the lymphangiogram shows very distinct and clear obstruction. But I think that the other technique is more specific so that potentially we can map them out in clinic prior to them going to the operating room.
Okay.
Yeah.
Very interesting.
Does that answer your questions?
It does. It does.
So you mentioned that there's some people who come to you have a diagnosis of lymphedema, but the vessels are healthy. And maybe this is outdated knowledge now, but I remember when I was in training, it was you either have an obstruction or malformation, or there's too much fluid being created that the body can't handle. So with those people who are healthy, have healthy vessels, what do you think is going on, and what is done for them that's different than other people?
Yeah, for sure. So we definitely know more and more that there is subclinical lymphedema, right? Where we know that the vessels are still working, but they haven't come to a stage where there's what we call dermal backflow with eventual fibrosis. Okay. So the other thing to remember is sometimes these patients could have issues with their venous system or other systems such as the arterial system. So I have seen patients where they've had an actual diagnosis of lymphedema, and when I did further imaging and even assessed their skin color, the perfusion to their limb, I've noticed that they have other things going on as well, such as issues with arterial flow and venous flow. So unfortunately, like in the past, lymphedema has unfortunately been a diagnosis of exclusion, which I think has led to us not diagnosing patients early enough, right? So it has led to us seeing patients when they had very swollen limbs, right? Which, and now we are more cognizant of the fact that it's probably starting much earlier, that we have to watch them a little bit more. We have to be able to assess in different ways. So I think, but having said that, there is still a subset of patients that don't necessarily have lymphedema. There's also a difference between lymphedema and lipedema, which is the accumulation of fat as well. I do think that from a fundamental perspective, they do go hand in hand. They have an effect on each other. But I still think we still need more research on that, because we do know that things like adipocytes and some fat cells in the area are involved in the lymphedema pathophysiology. Where we have more and more evidence of that. So I think those two are closely related, but there is a distinction in the diagnosis.
So we know that lymphovenous bypass, I cannot speak today, and lymph node transplant are the techniques that are used with lymphedema patients right now. So how would somebody get access to those procedures, and what are the success rates?
Right. So the way they would have access to them is, one, they would be referred to a surgeon who would be doing those techniques. Those techniques are specific to the stage. So a lymphovenous bypass is a technique where working lymphatics that actually have lymph flow that are not fully fibrosed are actually divided and are sutured into a small little vein of equal size. Both those lymphatics and those veins are less than 1 millimeter in size. So a microscope is used to put those vessels together. And the goal is to allow the venous system to pick up this lymphatic fluid that typically accumulates in the area. So the goal is to get the venous system to take this fluid back, right? So there's less accumulation. Lymph node transplant is a different type of surgery where lymph nodes, along with the vessels that supply the lymph nodes, which are the artery and the veins, are taken from a separate area of the body. So these are healthy lymph nodes, and they are sutured in vessels that are located in the limb that is affected. So it's also a microsurgical technique. It requires a microscope in order to do this technique. And the goal is not so much to allow the existing vessels to reconnect, but rather to create new lymphatic vessels. So we call this lymphangiogenesis, right? So that's the theory behind doing the transplant. So typically for somebody who's at stage one means that they still have pitting edema, and pitting edema is always a good thing because that means you can actually work with that fluid. A lymphovenous bypass is typically the better option. And lymph node transplant is reserved for somebody who's between a stage 1 to a stage 2 and probably a little bit later, okay? Because you can no longer bypass these vessels. You want to create new vessels.